Oh, you put it here? Oh.
Hi guys, can you
Hello.
see
Good
us?
afternoon.
Can you see us?
There's no moderator, they said. Remember.
All right. So, okay, can you show the video of the hospital, please, first, Pedro? We're just going to show the. I like to show. Oh, great. That's great. Asma Hosseini, she's the leader of our heart team. Asma, do you want to present?
Yes. So
First, introduce the heart team, Asma.
So we have a large heart team here, beginning with, of course, Dr. Carr, Saibal Carr, and then we have another interventional cardiologist, Dr. Vishwa Dev, and then our CT surgery team consists of Dr. Gregory Fontana, Dr. Amr Shah, Dr. Mohammad Zadeh, and Dr. Philip Faraci. Our anesthesiologists who also do RTEs for us, we have Dustin Lloyd, Andrew Gabriel, Steve Vaskanian, who's here with us today, and Andrew Cannon. And then APPs is myself. I'm Asma. I'm a PA. And then we also have Kelly Hall from CT Surgery. Our valve coordinator is Diane Delgado. And then we have our director of cardiovascular services, Lisa Bear. And then inside the room today, we have Colleen, who will be helping on the case. We have Gabe on the MitraClip device. We have Pierre from Abbott and Ali from Abbott. And then we have Kathy, who's our nurse in the room. And then we have anesthesia, Steve Vaskanian. So let me tell you about our patient. He was just seen in our clinic last week. He's a 63-year-old male. Next slide, please. 63-year-old male who came in with NYHA class 3 symptoms of shortness of breath. So he becomes short of breath with normal everyday activity. He has a past medical history of hypertension. He has a urologic cancer for which he had a right nephrectomy, a urerectomy, and he's had chemotherapy. So he was seen last year by our surgeon, Dr. Mohammadzadeh, and was offered a surgical repair in October 2022. But unfortunately, he developed back pain and leg pain, which was initially diagnosed as sciatica, but then this year, PET scan confirmed that he has metastatic disease to his pelvic organs and to his lungs. So now he's been referred for MitraClip before he can start chemotherapy. He's not your normal high-risk surgical patient. He has STS scores which were low, 2.4% for mitral valve repair and 2.6% for replacement. He was seen by Dr. Zadeh and recommended to proceed for MitraClip therapy. I'm going to turn it over to Dr. Viscon, who's going to go over the TE findings.
Good afternoon, everybody. Um, upon just placing the echo here, they see my echo pictures here. Asma?
Actually, this is the outside
Oh,
transthoracic, I'm sorry. So he's got normal LV function. His LV size was normal. Next slide.
And then Pedro, switch to
live, yeah.
live, switch to
Sure. So
live
I think
T.
we can just switch to live and go over the TE imaging.
All right, upon initial review,
Can you make echo large? Yes. No, take away the PowerPoint. Pedro, yeah, that's great.
All right, upon initial review, you could see a very large prolapsing posterior leaflet there. You can also appreciate a large left atrium, which is suggestive of a kind of a chronic issue going on here. And with the color, you can see a very, very nice, solid, large jet, anteriorly mediated jet with a kind of a wall-hugging effect, suggestive of severe MR. So as we progress down here, again, this just shows the large jet with the PISA there. And on X-plane, you can appreciate the prolapsing leaflet on the
5,000
lateral side there.
Kathy, give 5,000 heparin.
And
5,000 heparin, Kathy.
And on 3D here, you can really appreciate the large prolapsing leaflet. Approximately, basically all of P2 there is prolapsing, and you can appreciate the leaflet there, right there on the medial side is yeah. Sorry about that. Hold on one second here.
What happened?
I don't know, just my
That looks good.
mouse kind of went through it.
Huh?
And on Color 3D here, you can appreciate the large jet centrally right there, all across the coaptation line, especially medially, with the prolapsing leaflet. And good
That looks-
ventricular function. We got a mitral valve area of about 5.2-ish. And we also use multi-plane reconstruction here. Right here, you can appreciate the valve in different planes simultaneously. And
Pedro, show fluoro now.
we got a
You get the echo
baseline
this side.
gradient of about 3 across the valve.
Fluoro small, echo large.
All right. Now I'll
Echo.
pass it over to
echo.
Dr. Carr here.
Yes, that's good.
Yes.
Pedro, I need echo large. Yes, that's good. Perfect. And you can show my hands in one side in the corner. So this is a, thank you guys. I mean, very excited to show this case. And we wanted to do this absolutely skin to skin. I didn't even see the T till I came into the room right now. And I just saw the T. We had Steve Bosconian. We had better echocardiographers, but they were not available today. So we got Steve Bosconian to do a case, but it's not too bad.
Yeah.
You're doing not a bad
You
job.
can even clip this
Yes.
bit, Dr. Carr.
So we have now, we're going to do the transeptal live, and Colleen's on my right side. Colleen's going to help me. So what we don't use any fancy needles, we just use the BRK and SL1 sheath. So I've got a 8 French sheath. I've pre-closed it with 1 per close, and now I'm ready to do the transeptal. Steve is showing me the wire position. And the catheter, you can see, is in a bicable view. My goal is to be around 4.5 centimeters above. On the right side, I did introduce Ali and Piro. Ali from Abbott and Piro behind are from Abbott over here. We were thinking of using a Pascal device, but then we decided to use a MitraClip because the Pascal is a bit too expensive. So we are now advancing the wire inside. And it's right over there. And so we'll take the BRK needle. What I do is with the needle, if you can see, I actually make an additional bend to the needle. I make a little additional bend. And then I'm just going to advance the needle into the transeptal. So Steve, you're going to show that view, right?
Yeah.
And you're going to tell me whether you like it or not.
Yeah.
So I'm just going to come down. Steve, stay in the septum, Steve.
Yep.
Show me the fossa. Yeah.
Got it.
So we're coming down a little bit more. I'm just going to clockwise the needle a little bit. It's still high up. And I'm just going to come a little bit more down. Yeah, I'm trying to come down a little bit.
There.
I like that position,
You're
right?
on that thin part there inferiorly. Nice.
Yep. We want it to be mid fossa. And you want to see short axis?
Nice
I
posterior.
think short axis is quite good, right? You want to measure the distance?
Measure the.
Measure.
Yeah, so we quite now, so the short axis are posterior, so we want to see the dist. It may have gone through. No, I don't think so. Oh, no, maybe
Oh,
it
you
is.
did,
Yeah.
Yep,
Can you see
you're
the
through.
short axis where it is? Right. Actually, the needle went through.
You did. I saw your. Yeah.
Okay. That's actually quite posterior, right?
Yeah.
Yeah, I think that's a nice position. I think I'll accept it. So it just went in through a tent, but you know, it's very posterior, so I think we should be okay. So I'm advancing this dilated through. Now the sheath is inside the left atrium. Can you see? That's great.
Find them.
So we are in the left atrium. We're going to measure pressures in the left atrium. And how much of heparin did we give, Kathy? Kathy, how much did you give? 5,000. What does he weigh? So let's give another 3,000 of heparin. And now I'm going to go 2 wires in the left atrium. So we're actually measuring the distance. I think it should be all right. No, don't go so low. Why are you going so low? You should level at the annulus. So we're measuring the distance annulus, right? Yeah, that's good. That's correct. Yeah. So you're just measuring the distance, right, from there going up till there should, wow, it's actually not too good. So we might have a height issue. But let's see, but we are as posterior as I could get it, right? So we may have to use some advanced techniques to advance the wire. So I'm advancing the wire into the pulmonary vein. See that?
We'll show you where you're at.
Yes. And now I'm going to get the second wire. So I put two wires in the left atrium. One soft wire and a second stiffer wire. So just a stiff wire, I make a curve to it. This is a super stiff wire, 035. And I'm just advancing this wire into the left pulmonary vein. So now I have two wires in the pulmonary vein. Okay, and now I'm going to keep the wires in place. And actually, so I want to show Pedro, on one side the hemodynamics when I get it. And I'll tell you when to show it. Okay, so let me pull this out.
Posteriors, you can go, right? That's posteriors, we can go, right?
Yes. Okay. So now let's go to this, and now let's. So I'll put a pigtail catheter. So, Pedro, I need a catheter for a pressure tracing now. Hemodynamics. Can you show hemo? Yes. That's good. Actually, that's quite good. Can you show all four? Hemo, fluoro, and view in the corner? I mean, hemo, if you can do small, it'll be okay. Okay. So I'm just putting a pigtail catheter into the left atrium. Advance it in. Yeah, that's good. I like that. So when we grasp, we're going to do a two-screen technique. So, sorry. So the catheter is inside. I'm just going to pull it out a little bit. Okay, good. So you can see the pigtail catheter is in the left atrium, actually. And so we have one catheter over the pigtail. The second will be the guide catheter. So aspirate. And that's going to give you continuous left atrial pressure. So if you can give me the left atrial pressure and lock it and then spread it out and open it to pressure. No. Okay, so that's left atrial pressure. It actually is quite good, actually. The V wave is not very prominent. So the patient is quite compensated. What was the pulmonary vein flow like, by the way?
Systolic blunting.
Systolic blunting.
Yes.
Okay, got it. Okay. I didn't see that, but you can show it to me. Okay, so I'm just putting it in. Now you want to take this out? Mm-hmm. So I'm dilating the tract with a 20 dilator, and now I'm going to advance the guide inside. Yeah, I think the puncture site is pretty good.
Yeah, just come out with the clip a little slower.
So now we're going to come up with the guide. Lisa, how are you being? Lisa's overlooking everything over here. Are we behaving okay? Just Gabe, advance the catheter. Just advance a little bit more. Yeah, no. We are bending the wire. Yeah. Okay, good. All right. So now we're going to advance the guide through the groin. And I'm just going to show. So actually what I want you to do now is make echo large with fluoro on the corner, and so that I can show mainly echo being the main focus. Pull the wire, please. This is pulling. I don't like this. Okay. Yes, that's good. I like that. And then fluoro, and then you can show our hands on one side, 3. And you can show the hands. Yes, that's great. That's actually with fluoro on one side. Take the hemo off. Yes, that's great. So we're going to get in like this. I'm going to cross the septum, hold the wire. Make it pull it in. So I'm advancing the guide through the septum, and I'm just jiggling it right through, gently advancing it, and I think I'm inside, right?
Yep, you're inside.
Okay. All right. So now let's put the stabilizer on. Okay. That's good. So he's on a short axis view. So I'm going to pull the guide back a little bit. Lift this up. Just lift this whole thing up. Yeah, yes. Yeah. And let me just pull this back. Okay. All right. I think it's good. Okay. Let me see how much of guide there is. So I actually like only a centimeter of guide. I think that's enough, right? I don't want to pull it back too much. And now I'm ready with the. Okay. That's okay. That's plenty. So I'm first pulling the dilator inside, and now you can pull the wire. Yep. And I'm aspirating as I'm pulling. You can start pulling that to me. Pull. And I'm going to aspirate now. So making sure there's no air in the system. There's little few bubbles there, so I'm just getting them out. And once I get the bubbles out, I return the blood back. I don't like to lose any blood in these patients.
Yeah, a little more than that actually. You're good.
Yeah, we got plenty in.
Yeah, plenty.
Yeah, I'll actually pull the guide back a tiny bit more. I only need a centimeter of guide inside, and I think there's more than a centimeter guide. It's actually
That's
easier
good.
if you have
That's
less
good,
guide.
Saibal.
It's a trick, and you should be perpendicular. So I'm going to make sure it goes to the wall. You want to flush it? So we've got the clip delivery system. Can you lift it up? Okay. Lift it up. Good. Okay. Good. I like that. Now it's in. Okay. So I'm advancing the system.
Come out slowly.
The clip's going to come out soon. You can decrease the flush. Decrease the flush. It's too much. Gabe.
I know.
Okay, that's good.
Yep, you're out. You're in the left atrium there.
So very nice. You see how Steve is very nicely following the clip, which makes it easier for me. All right, Pauline, do you want to turn? 1/4 turn?
1/4?
Yep. Good.
My face look. It's not like I use it.
Okay. And then let's do another 1/4 turn. Fully. Yep. Good. Good. Is it coming?
Access, you should see us. There you go.
Okay.
You're right on the valve there.
Yeah. So posterior torque. Okay. So let me just get an R. I usually like to work an RAO. It gives me an idea. So I still think I should do now posterior
I
torque.
think we're still pretty anterior.
Yeah. Okay. So very posterior movement. Now I'm bringing the clip down. And I think now it's really good.
That's weird.
Okay, so it's very, very posterior. So I just pull it back.
There you go, Saibal.
Okay, this is not bad, huh?
Can you pull your
So we
hand
have
back?
a height issue. So we are going to have a bit of a problem to the height. So I'm actually going to do some maneuvers. This is a good case to show some advanced maneuvers to get height. So what I'm going to do, I'm going to clockwise the guide to get a little height, which I did. Then I'm going to use the A knob to bring it up. And then I'm going to pull the system back. I don't know why it's not pulling it back, right? And then I'm going to use the M knob to bring it down further. And now I've got a little bit more height, right? And I can do a little positive to the guide. It'll actually help me if I give some positive to the guide. And then I'll just use a little bit more A knob and a little bit more M knob. And then I think I'm in a good position. I don't want to give too much of... It's actually not bad. Sorry. No, Steve, stay like that. You're actually quite good. So I think I should give a little bit more M. You agree? So I'm going to go inside a little bit and then give a little bit more M to make the valve down. And then go a little bit more in. And actually, that's really nice, right? So it's very medial. So I'm just going to go more. You may have to decrease the tidal volume.
Yeah.
The tidal volume is too much. What's the tidal volume?
500. We're gonna go down.
What?
Here.
500?
What's that?
How much?
450. Sorry.
No, make it 200.
Yeah, it's coming down.
Yeah, okay. We actually decrease the tidal volume a lot because if we don't decrease the tidal volume, so we're going to go a little bit more medial. Yeah. So why is it? There's something going on here. Is there something in the groin? This is a problem. No, nice and straight. Okay, good. I could understand why it's. Yeah. No, I wanted to come middle. That's it. Okay, so now we're going to open the clip.
Stay on the clip. We're going to open up here.
Open the clip. Open it.
Open.
Yeah.
Raise the grippers. Unlock the clip. Clip is
Yeah.
unlocked.
Okay. 3D end face. So we're going to do 3D end face to see where the clip is. So we need to do a little bit of counterclockwise, right? So we're going to counterclockwise, and I'm going to transmit the torque, and it's going to turn. So we don't have much of height, so I'm just trying to. This is very key that you do the transmission of the torque. And now I think it's nice, right? And then I just give a little tension away, because others you don't give away tension, it over rotates below. Okay, it looks nice, right? So let's go to BICOM LVOT. That
Yeah.
looks nice, right? I think.
To me,
Yeah, I'm just wondering if you want to counter just a hair, maybe.
Yeah, but I think it's going to turn over because I've overturned.
Okay.
So let's go to BICOM LVOT. I think I like that position, right? It's on the medial side because we know we most likely will use 2 clips.
You want to check your grippers?
Yes. So when he gives us the view,
3 cc's. Thanks.
we'll check the grippers. Okay, that looks good. So let's check the grippers. So I'm going to take one. So the dot is anterior. You see that?
Mm-hmm.
And the blue is posterior. So we've checked the grippers. And I think what we'll do now is we should see if it's diving. I have a feeling it's diving medially. So I'm going to take off a little bit of M.
Nice.
And then I'm going to pull it back. Right? To be on the medial side. And then I think I shall go in like this. Correct? So I'm going to close the clip. See, I think it's still, I think I can take a little bit more M off. And actually, it's even better looking. Good. I like that. Now I'm just going to close the clip. And I'm going to go down into the valve. Yeah, a little bit of M. That's okay. We can give the M even later. So we're on the medial side, right? We've gone inside, right to the valve.
Yeah.
And now we're going to open the clip. Okay. And you want 3D end face? Yeah, maybe I'll move it a little bit, mommy. So let's do some color here. Just see where we are. Let's put color here. Yeah, I think this is a good spot because we lateralize the defect a little bit, right? A
It
bigger
looks like you're
medial jet,
splitting
a
the
small,
jet there. Yep.
right? And then let's do 3D end face. Okay, so I think we're almost there. Maybe we should hair clockwise, right?
Hair clockwise, yeah.
That's better, right?
Beautiful.
Okay, let's go back to BICOM LVOT. And I might move the clip a tiny bit inside. I mean, it's already grasping the leaflets. How about that? Looks really nice, right? So
more
both the
anterior.
leaflets are on, right? Huh?
Just flatten out your posterior. It looks like it's kind of doubled over.
So much redundancy on that leaflet. So much redundancy. Yeah. It's hard not to double it over.
I missed it.
Not sure you got posterior.
Now I've caught. Okay. Okay, got that. Missed the posterior.
Close the hair too, Sybil.
And now I've got both. Okay, so let's see 3D end face.
Close to 120 just to drive it in.
Yeah, but I wonder whether we're too medial.
Let's see.
Close your clip just a hair.
I did.
Okay.
Okay. The orientation looks perfect, right?
Looks good.
Yeah, it looks
Yeah.
great.
No. BICOM LVOT.
You want color?
Put color now.
Color, yeah.
Put color. Okay, that's good. So let's close now. Okay, Colleen, want to start closing? Close color off. Slowly. Okay. Go tighten. I want to see the pressures in the left atrium. Can someone show the pressures? Can you show pressure, Pedro? The left. Pedro, show pressures? Yes. Hemos, sorry. So I think we've got a nice grasp. The left atrial pressure is completely changed. Let's see color now. There's no medial jet, there's a tiny lateral jet.
Tiny laterals, yep.
Right? Yeah, we'll put a second clip on the side. So I think we should just put a second clip. I think, do you want to see let's go through the drill. The LA pressure has significantly gone down. Let's look at the gradient.
Oh, nice.
All right. Is that a late systolic reversal? But that's all systolic prominent, right?
Yeah.
Now, what's that deep S wave like that? That's S1? No, that's A.
That's A wave.
That's an A wave.
That's A wave, yeah.
But the S it's prominent,
Yes,
right?
absolutely.
Okay, good.
Yep.
So the S wave is prominent by pulmonary veins. Now let's look at the color.
You want me to get a gradient too?
Yeah. So we're measuring a gradient. So Steve, are you having problem doing echo? Do you want me to scrub and do it?
I'm having a blast.
I want to make sure posterior is in. Like
It is in. So you can see that the E wave is less than the A wave, right? Do you see that? That's a good sign. That means we've got the MR. The other option is that we can just try one clip and put it in the middle. You want to do that?
I just want to make sure you've driven your posterior all the way in. Ooh.
6, okay. So I think this we cannot do two clip case. So we got to move this clip and bring it right in the middle.
Yeah.
Okay?
Balance it out.
Yes. So what we're going to do is we're going to open the clip.
By convex line.
Yeah.
It's fascinating, huh? That you can do, and then we'll see.
Sorry.
Heart rate is 91.
Yeah.
No, the posterior leaflet is in. It was very nicely in.
No, it's very nice. Yeah.
Yeah.
It was actually very well in. I just pulled it back, but we're going to go down, and I think I'm just going to move the whole system more inside, or take off a little
Want
bit
to
of
open it up
M.
to drive it in?
I'm just going to open it up. And I'm just going to be, can you do color and show me where we are? Yeah. So we can just either push this out. 181? That's okay. We'll be done with this case soon. So put color. So we're not in the middle now. Put color on. See where we are.
Go
So
pretty
I
lateral.
still
You
think
might-
we should come a little bit more medial, right?
Yeah, it seems like you're lateral.
Color off. Color off.
So see how it's kind of
Put color there. This is splitting the jet. I think we should go a tiny bit medial, right? And we'll be left with a small lateral jet. I think it's okay. 3D end face. So we're right in the middle of the case. Okay, a little bit of counterclockwise, correct?
Yeah. Or clockwise.
No, counter,
Okay. Oh yeah. Yeah.
right?
Yes. Yes. I thought you meant the clip. Yeah.
All right, so let's go back again.
So see how it's kind of curling your posterior?
No, this is better than the previous grass. Color on. I just am worried about if we will have a bigger gap medially. Color off. I'm biasing it slightly to the medial side. And I'm just going to come up.
So see how
This-
P is just kind of curling a bit?
That I can't do more than that. A maximum pulling, and now I'm just going to drop it. It's got it. Okay, 3D end face. I'm going to close the clip.
120 to drive it in.
Like that. So I'm going to lock it early, and I'm going to go down. Okay. It's okay. Orientation looks great.
Yep.
What do you think tension is? Oh, it came out.
Oh. Huh.
It just pop out,
Flipped
right?
off. Yeah.
I think because it was not, it was folded over.
It was folded over. Yeah. There's a lot of redundancy on that posterior leaflet. Just keeps folding on itself.
Okay. So 3D.
Yeah, so see how it's folding?
Now I like it.
That looks like it.
3D end face.
Close it a bit though to drive it. I don't want it to come out.
Okay. 3D end face. Now it's turned, right? So I'm going to pull the grippers out. I'm going to go inside, and I want to counterclockwise a little bit.
Yeah.
Okay, right? Bicom LVOT. I like that.
Posterior needs to be unraveled.
Huh? There's nothing I can do because the leaflet is like that. Now it's got it very nicely. Good. This is really good grasp. Okay, so I'm going to close it 3D end face. Ah, it's off again, right? Yeah, so take it out.
You might be okay there, Sybil.
No, you see how it moved? I don't like it moving that much. Open the grippers. Can you see the orientation now before I drop it? I don't want to. Okay, so the orientation is good, right?
That's good.
Okay. So I'm going to close to 120.
Really drive that posterior end.
I think there's a lot of tissue in,
Locked.
locked.
Ready?
Got more tissue on this
You definitely got more tissue.
Yeah.
Very nice. Beautiful imaging, by the way.
Thank you.
one. Yeah, look at that.
That tissue bridge.
Yeah,
kinda going
nice.
there.
Very thick.
I mean, this is a huge tissue bridge.
Yeah.
Okay.
Beautiful bow tie.
The echo looks really nice. Okay. You want to see the color now? Ah, there's no MR.
Very nice.
Okay, so we're going to look at, so when we go like this, we actually go, Colleen, that's the heart, by the way. Sometimes we have to remind Colleen.
You do.
She thinks it's the aortic valve. That's the mitral, Colleen,
Okay, good. Thank you.
You're closed all
In
the
the
way?
heart.
in the heart.
Okay.
Looks great.
Fully closed.
We have problems in our staff here. Colleen, stay awake.
Stay focused.
Stay focused.
A little bit on the lateral there.
So I think that's a small jet, which I don't think we should worry about.
Right.
Let's look at everything. So the color jet is really definitely growth. The leaflets are grassed. Let's raise the gradient and the pulmonary veins, and then we can deploy. And you can see the image, the pressure tracing. So let's look at the A wave. Oh, look at that.
Oh, that's better, yeah.
That's, you can see that significant systolic dominance, which is very good. Let's look at the right upper. That's even better. See that? The first wave? So that means the first wave is first. So that's great. Now let's look at
Want a
gradient.
Yep.
You should do an LVOT view.
Sure.
Heart rate's
Right?
91.
Yeah, that's good. And now you can see the E wave is still less than the A wave. See the first wave? So that's usually a good sign. That means no MR. That's good.
Oh, do you need to be on here?
And I think the gradient is better down.
Right here. Versus you're on aortic though?
No, it's all right.
Doesn't matter.
No.
Okay.
Still gonna
Go
get
right. No, down. Right down. At
Four.
the height of the R wave. You should take at the height of the R wave is.
Yeah, that straight
the
line
end
down.
aspect.
I know.
Yeah.
It kind of,
Okay, that's fine.
the mouse slipped from my hand.
So it's 4. So that's actually much better. I think we should accept this and let's do a 3D picture and then we should deploy. Right? You guys like? So I'm just going to do a fluoro image to see the clip, what it looks like. It's actually, wow. So fully fluoresced. I'm just going to, Colleen, tighten the clip. So you see, yeah, really.
Yeah.
So we have plenty of tissue. That's why it completely closed. The 3D looks great. So we're going to start deploy. So you can start focusing on my hand and fluoro and the hand. Okay? Make fluoro
looks great.
and the arm large. And Colleen's going to do it. Colleen, go hold this.
Okay.
All right? So make sure that the grip is inside. Right down. Good.
Okay.
Perfect.
Okay.
Let me see if it's tight enough. Good. Now try to open the clip. So she's going to open the clip. Good. And it's not opening with fluoro. Good.
It's a lot better.
Okay.
Tighten it again. Just tighten it again. I just want to see it
I think
tighten.
it's like maybe like this. She couldn't see the
Okay.
Okay.
like on top of it. It's
Let me see fluoro.
on top of it.
And now open it again.
You know it's okay.
Neutral.
Neutral.
Okay. It flax opens up and then positive side of neutral.
Yep.
Good. Now this one. Yep.
Up with the droops.
When do they put a clip on it?
Okay. Good. pressing it inside, right? So you can see this is the gripper line, and we're actually trying to separate the two strings.
Flora?
Flora? Looks good, right?
Yeah, it was.
So,
Okay.
Blessing.
no,
Pull
good.
slowly, Colleen.
So, Colleen, when you're pulling this, you should also be looking at fluoro. So we're looking at fluoro to make sure the clip doesn't open up, which it's not. The function of the heart is really good. Okay, very good. Good, it's completely out. Now close the clip again, tighten it. This is superstition. I just tighten it up once more, completely, and then go to neutral. Good, very good. That's it. Then open that. So now we're going to deliver the shaft. So she's going to come off. Yeah.
Do you mind
Yes.
noise cleaning? Let
Yep,
me get a
sure.
quick second.
Okay, that's good. Keep
You
coming.
see it? I
No,
just
no, no,
wanna
no,
see-
no.
I just
no,
want to see it.
Yeah, yeah.
You've got some tension
Just
on
a
the
little.
shaft,
No, yeah.
Bible.
Okay.
No, that's enough.
There it is. And then,
Yeah. Okay.
Bicomics line.
Yeah. Go ahead.
okay.
Yeah.
So 1, 2, 3, 4, 5, 6,
7 and 8.
8.
And then you just
Pull
pull back a little bit, and then pull that
Pull.
together. Very good. And your clip is
There,
deployed.
released. You're off.
Super stable.
Still stable is very good.
We'll follow.
And so once we're in like this, we gently start taking out the M knob, the P knob. Yeah, so I'm just going to start counterclockwising the guide.
Yeah, right.
Oh, he's still there.
Yeah. All right. Do you want to share this one?
Flora stable.
Yeah.
So see, the LVOT shows the movement from the residual. It's not posterior, you know?
Is the clip back?
Yeah.
So let's go pull it out. Aspirate. So we have a small medial jet, but we knew that we're going to get that. I don't think if we put a small clip there, we turn that. That's okay. Good.
Yeah.
Yeah. So the question is whether we should put another clip there, and I'm just worried about with the gradient that it'll be a problem. So we may not be able to put another clip. We got a very nice tissue bite. What are you concerned about? Gradient? Yeah.
Thanks.
So that's the gradient. And take the modal velocity. So okay, good. Yes. You should take the white deep part. Yeah, that's it. That's it. And go straight up to the white line. Yep. 5, yeah. I think we can't put another clip,
Yeah.
right? So we're getting a gradient 99. We have a small medial jet. We've got a nice tissue bridge. Just show the 3D. And I think we're done over here. And you show the hemodynamics, Pedro? Echo, always echo up. Fluoro is not important.
How about
Echo.
LV?
Pedro,
Atrial pressure.
echo, and hemo. Don't have to show fluoro. Hemo. That's it. You can see it's a prominent A wave and a no V wave. And this is what it was. Now you can see that we've got a clip right in the middle of the valve. And there's a smaller medial orifice, a tiny jet there. And it's a very nice tissue bridge. So I really like this. So we're going to come out with the guide. This is a beautiful picture, by the way. This is really stable, right? And the lateral orifice is bigger. The orifice
Great
size is
tissue
not
bridge.
that, right?
Yeah, very nice tissue bridge.
Yes. So what I want to show you, I want to show you the hemo. Focus on the hemo pressures. And the mean LA pressure is 7 now. And can you show the hemodynamics? And I'm going to pull the guide back, and we'll see what the pressure happens. It sometimes goes down. And actually the pressure has remained same. It just went to 6. So that's the other pressure. So let's now look at echo. And I want Steve to take care of our echo while I'm just going to take care of the groin. So echo on side and fluoro on the and imaging right on the groin where I'm going to pull this out. Yes, we can take it out. So we're pulling out the guide. We have a 6 French pigtail and 4 French pigtail. There's a bit of bleeding. I'm just going to try to tension the suture in. It looks nice. Can we? So there's a little bit of bleeding, but now with 1 perclose, we never use 2 perclose. We just use 1 perclose. It's already much better. And I'm just pushing the knot in. And I'm going to tighten the knot. And then I'm going to just use an extra figure of 8 stitch. And that's it. So let's get a figure of 8 stitch.
But it was such a redundant leaflet, right?
Yeah, it looks great. I mean,
You could even
from the
tell, like,
prolapse and the torn cord,
Oh,
this
yeah.
is looks great from here.
even like when you go to a Bicom after the clip, you don't see like that big falling,
So I'm putting a figure of 8 stitch in the groin.
much
Yeah.
prolapse up.
Toilet bowl.
Yeah.
Can you do this needle? Yeah. Can you load it?
Maybe, when you're done, a pre-post or a Bicom explain with color.
That's right. So we're putting this figure of 8 stitch down. Just taking a nice bite of the. Put it here. Okay. And I take a nice bite coming out from this side.
There we go.
Good.
Yeah.
So I'm just tightening the stitches in the groin.
Very nice.
1,
Then you gotta post the 3Ds right with the
Yep.
2,
Yep.
and
I'll
3.
just do it now, just in case I didn't get a good one.
And here. This is the fisherman's knot that I'm doing in the vein.
Yeah, it was buckled. There was like a torn cord, so part of it was going like that. So
No one's been talking this whole time.
yeah, yeah.
Shoot. Let me, yeah.
It's so redundant, right? It's just-
Longer tail. 1, 2, 3.
Yeah, because then it slips, right?
and essentially naturally this happens, you know?
Right.
Push
Yeah.
things you're out.
Okay. And it's going down. So we tighten the knot. Skin is like there's no bleeding at all now. And then we just tighten it. That's good. So you can see that there's no bleeding at all. 1 venous stick. We had no arterial line in this patient, right?
Correct.
And no pericardial effusion by echo. Can you show echo large? Let's show the final pictures. And I want the whole team to come here, please. Can you come, all of you guys together? Asma, all of you guys come. Gabe, Sophia, and Steve. Yeah. So there's no pericardial effusion.
Correct.
Look at. Can I show the ASD, please?
Yep.
Kathy, come here. And can I see the ASD?
Yeah, I had it right here.
Right? So there's a small ASD that's less than 5 millimeters, I think. It's all left to right.
Yep.
So we don't need to close that. So if you come here, guys. I also want to acknowledge Pedro from Medistream, who's been moderating and helping me out. I'm very grateful to Samin Mehta, Samin Sharma, and the whole organizing group to allow us to present. I do want to thank the people in the room. I will start with Asma, Gabe Oreda, Colleen, I want Ali and Piero from Abbott and Kathy. Kathy, say hi. Kathy, come this side. Say hi.
Gonna find you.
Kathy, the camera's going to find you. Kathy. And Sophia, who's hiding behind. And thanks for everybody. And it's, I hope you guys have enjoyed this case. And hopefully we'll see you soon in a couple of weeks. Thank you.